Toxic nutritional optic neuropathy. It is also known as toxic amblyopia. It's basically chronic retrobulbar neuritis. Here the visual loss results from damage to optic nerve fibers due to effects of exogenous or endogenous poisons. It is frequently bilateral and has a chronic course with permanent visual deterioration. The toxic agent involved may be tobacco, ethyl alcohol, methyl alcohol, ethylene glycol, lead, arsenic, cannabis, indica, etc. So, varieties of toxic amblyopia include tobacco, ethyl alcohol, quinine amblyopia, ethambutol amblyopia, tobacco amblyopia. Typically occurs in men who are generally pipe smokers, heavy drinkers, and have diet deficient in proteins, vitamin B complex, and it's also labeled as tobacco alcohol amblyopia. Pathogenesis: it is caused by excessive use of tobacco by smoking and chewing. The toxic agent involved is cyanide in tobacco. Clinical features: the condition usually occurs in men between 40 and 60 years and is characterized by impairment of central vision. It's bilateral and gradually progressive. Patients usually complain of fogginess and difficulty in doing near work. Visual field exam revealed bilateral centrocecal scotoma with diffuse margins which are not easily defined. It is greater for rest than for white color. Toxic amblyopia, excessive tobacco smoking, decreased cyanide detoxification due to alcoholic diet is deficiency of sulfur-rich proteins, excessive cyanide in blood, degeneration of ganglion cells, particularly of macular region, degeneration papillomacular bundle and nerve. Toxic amblyopia. Contact system is essentially normal or there may be slight temporal pallor of the disc. Treatment: it consists of complete cessation of tobacco and alcohol consumption, hydroxycobalamin 1000 microgram intramuscular injection weekly for 10 days. General health and nutrition. Ethyl alcohol amblyopia, it is often associated with tobacco amblyopia, heavy alcohol drinkers, and it is suffering from chronic gastritis. And clinical feature and treatment is similar to tobacco amblyopia, but prognosis is not so good. Methyl alcohol amblyopia, unlike ethyl alcohol, poisoning by methyl alcohol is typically acute, usually resulting in optic atrophy and permanent blindness. Etiology: it usually occurs due to intake of wood alcohol, methylated spirit in cheap adulterated or fortified beverages. Sometimes it may be also be absorbed by inhalation of fumes in industries where methyl alcohol is used as solvent. Pathogenesis: it is metabolized slowly. Methyl alcohol is metabolized slowly. It is oxidated into formic acid and formaldehyde in tissues. These toxic agents cause edema followed by degeneration of ganglion cells of retina, resulting in complete blindness due to optic atrophy, edema, and then followed by optic atrophy. Clinical features: general symptom of headache, dizziness, nausea, vomiting, delirium, etc. Ocular features: patients are usually brought with almost complete blindness. This is noticed after 2 to 3 days, and stupor wanes off. Fundus examination in cases reveal mild disc edema, markedly narrowed blood vessels. Finally, bilateral primary optic atrophy ensues. Treatment includes gastric lavage to wash away the methyl alcohol should be carried out immediately and at intervals during first few days, as the alcohol in the system is continuously returned to stomach. Administration of alkali to overcome acidosis should be done in early stages. Soda bicarb may be given orally or intravenous. Ethyl alcohol, it should also be given in early stages. It competes with methyl alcohol for enzyme alcohol detonase, thus preventing the oxidation of methanol to formaldehyde. It should be given in small frequent doses, 90 cc every 3 to 3 hours for 3 days. Eliminated treatment by diaphoresis in the form of peritoneal dialysis also helpful in washing alcohol. Prognosis usually poor. Quinine toxicity. Patient may develop near total blindness, deafness, and tinnitus may be associated. Pupils are fixed and dilated. Dilated pupils, fixed pupils. Fundus reveals retinal edema, marked pallor of the disc. Mostly edema is seen in this condition. Extreme attenuation of retinal vessels. Visual fields are markedly contracted. Ethambutol, it is an anti-tubercular drug. Ethambutol toxicity usually occurs in patients who have associated with alcoholism and diabetes. The clinical feature mostly occur optic neuritis and typical central scotoma. Involvement of optic chiasma may result in true bitemporal hemianopia. Patients usually complain of reduced vision or impairment of color vision during the course of anti-tubercular treatment. Fundus examination may reveal signs of papillitis, anti-ischemic optic neuropathy (AAON), and it is divided into arteritic anterior ischemic optic neuropathy and non-arteritic anterior ischemic optic neuropathy. The first one, arteritic anterior ischemic optic neuropathy. Etiology: it results from inflammatory and thrombic occlusion of short posterior ciliary arteries caused by giant cell arteries. It usually occurs in older patients Mean age 70 years and accounts for only 5 to 10% of S of AION. Clinical features: systemic or other ocular features of giant cell arthritis may also be associated with AION. Systemic features of GCA include headache and tenderness of temporal arteries and jaw claudication. Characteristic pain on speaking or chewing. It's pathognomic of GCA. Ocular presence of GCA other than AION. Transient ischemic attacks, amaurosis fugax may precede AION by several weeks. Central retinal artery occlusion or cilio-retinal artery occlusion may sometimes be associated with AION. Ocular ischemic syndrome due to involvement of ophthalmology is comparatively rare association of AION. Diplopia may occur due to ischemic bursts of extraocular muscles. Features of AION are follows. Visual loss is usually marked and sudden, may be preceded by TIA. General features of GCA present RAPD present markers in people, optic disc edema, peripapillary pallor, temporal arteries loose pulsation become tender. Investigation fundus fluorescein angiography reveals delayed choroidal filling. Important differentiating sign from both of the conditions. Visual field show typical altitudinal hemianopia. ES and C-reactive levels are raised in patients with giant cell arthritis. Temporal artery biopsy is required for confirmation of diagnosis.